In the winter of 1918, a county physician working the hill roads outside Asheville, North Carolina, carried a leather bag that weighed less than 12 pounds. Inside it were a few glass vials, a set of instruments, a bottle of carbolic acid, morphine sulfate tablets, cotton dressing, and a small earthenware crock sealed with wax cloth. The crock held honey, dark, slow-moving sourwood honey from the previous summer's pull. He wasn't carrying it for his tea. When he encountered a wound he couldn't clean with carbolic, infected lacerations, suppurating sores, chest infections that had settled into something he couldn't name, that honey came out of the bag. He packed wounds with it. He mixed it into warm water and had patients drink it down for stomach complaints that wouldn't resolve. He'd learnt it from the physician who trained him, who had learnt it from field surgeons in the Civil War. No pharmacology behind it, no chemistry he could name, just a working observation passed down through the hands of men who'd seen enough to know what held and what didn't. He died in 1931. His bag passed to a nephew who became a dentist. The crock, presumably, got left behind. By 1945, penicillin was in commercial production. Sulfonamides had already changed battlefield medicine. The things that physician carried, the honey, the propolis tincture, the small vial of bee venom he sometimes used on patients with joints so swollen they couldn't close their hands, were gone from serious medical consideration inside of a decade. Not banned, not suppressed, replaced by something faster, more scalable, and better documented. That's how it works. That's how it should work. But here's what's worth sitting with. The honey in that crock wasn't working because of superstition. It wasn't working because of tradition. Something inside it was doing real biological work. Work that took another 50 years to name precisely. And in between the county physician's last house call and the first peer-reviewed study that explained the mechanism, a generation of folk knowledge went dark without anyone stopping to separate the parts that were real from the parts that weren't. What was real is worth understanding, and what wasn't is equally important to say plainly. If you've ever wondered which side of that line your great-grandmother's honey remedy actually fell on, stay with this. We're going to go through it carefully, and if this kind of historically grounded biology-first approach is what brought you to this channel, a like on this video goes a long way toward keeping this content in front of beekeepers who care about getting it right. To start with what honey actually is, chemically, not poetically, you need to set aside almost everything you've heard honey described as in the context of health. Not because those descriptions are wrong, but because they usually skip the part that matters most. Honey is, at its chemical foundation, a supersaturated sugar solution with a water activity of approximately 0.6. That number is the beginning of the whole story. Most bacteria that cause human infection require a water activity of at least 0.91 to reproduce. In a honey environment, bacteria encounter a solution so concentrated that it pulls water out of their cells through osmotic pressure. The bacterium dehydrates. It can't replicate. It doesn't develop resistance to this process the way it develops resistance to an antibiotic, because osmotic stress isn't a molecular target a bacterium can mutate around, it's physics. That's the first layer. There's more beneath it. Honey has a pH range of roughly 3.2 to 4.5, depending on floral source. Most pathogenic bacteria prefer environments close to neutral. That acidic pH is hostile in its own right, independent of the osmotic effect. And when honey is diluted, when it contacts wound fluid, for example, the glucose oxidase enzyme becomes active and begins producing hydrogen peroxide, slowly at low concentrations, enough to act as an antiseptic at the wound surface, not enough to damage tissue the way concentrated peroxide would. The county physician in 1918 couldn't have told you any of that. He didn't have the language for it, but the mechanism was operating in that crock whether he named it or not. When he packed a suppurating wound with honey and came back 3 days later to find the infection retreating, the osmotic pressure and the hydrogen peroxide and the pH were doing exactly what they do in a modern wound care laboratory. Here is the part most people skip over, and it changes the way you read the whole history. The Civil War field surgeons who used honey on infected amputations weren't practicing folk medicine in any mystical sense. They were working with a substance that had genuine antimicrobial chemistry. The outcomes they documented, reduced sepsis rate in honey-dressed wounds compared to wounds left open or dressed with cloth alone, were real observations of a real mechanism. The fact that they couldn't explain it doesn't make it less real. It makes it more interesting. There are documented military records from the Confederate and Union sides noting honey application to infected wounds. The Union Army Medical Department's surgical records from several campaigns include honey among the wound dressings used when other materials ran short. These aren't obscure folk accounts, they're institutional records, and they track with the biology precisely. By the time World War I came around, that knowledge was still present in rural physician training in the Appalachian Corridor, but it was already fading from formal medical education. The germ theory of disease was becoming the organizing framework for medicine. Antiseptics like carbolic acid were standardized, scalable, explainable within that framework. Honey was not explainable within that framework yet, so it moved to the margins. Not because it stopped working, because the explanation hadn't caught up to the practice. That gap between what a substance does and what the available language can describe is the thread that runs through everything in this history. Now, if you're finding this breakdown useful, consider subscribing. There's more of this kind of historically grounded, mechanism-first content ahead. The kind that takes old practices seriously enough to explain exactly why they did or didn't hold up. Propolis is a different story, and it's worth telling separately because the biology is different and the documented history is more specific. The Appalachian and Midwest beekeeping tradition of collecting propolis for medicinal use goes back at least to the 1840s. It appeared in various herbalist references of the period as a treatment for sore throats, minor infections, and dental complaints, but the most documentable and interesting use emerged in the dental practice of the late 19th century, where propolis was used as a temporary filling material, a sealant for exposed dental surfaces, and in some formulations as a treatment for periodontal inflammation. The chemical reason this worked is now well established. Propolis is a resinous compound produced by bees from tree buds and bark exudates. Its active constituents include pinosembrin, galangan, and caffeic acid phenolphylester, a group of flavonoids and phenolic compounds with documented antibacterial and antifungal activity. Against Staphylococcus aureus and various streptococcal species, exactly the organisms involved in dental and oral infections, propolis extracts show meaningful inhibitory activity in laboratory conditions. The dentists who used propolis formulations in the 1890s did not know any of those compound names. They knew that it worked on certain complaints and not on others. They knew it set hard and formed a reasonable temporary seal. They knew patients with certain periodontal presentations seemed to improve with it applied versus without it. That empirical knowledge was real, and the chemistry behind it was real. The practice faded not because the chemistry became untrue, but because the early 20th century saw rapid advancement in dental materials science, vulcanite, amalgam formulations, early cements, and those materials were more consistent, more scalable, and better standardized than a resinous compound with variable composition depending on what the local bees were working. That is what replacement by a better technology looks like. It doesn't look like suppression, it looks like a superior tool arriving and the previous tool getting set down. What remained, and what continues to be investigated, is propolis as an antimicrobial adjunct in settings where standardized pharmaceuticals either aren't available or have become less effective. The increasing documentation of antibiotic-resistant oral pathogens has renewed research interest in propolis precisely because its mechanism, disrupting bacterial cell membranes and inhibiting key enzyme systems, doesn't trigger resistance development the way antibiotic use does. The 1890s dentist's intuition about which cases responded was pointing at real biology. The words for it came later. The most precise and most verifiable piece of this entire history involves one man, one clinic, and a question that modern medicine still hasn't fully settled. Dr. Bodog Beck was a physician who emigrated from Hungary to the United States in the early 20th century and established a clinical practice in New York. In 1935, he published a book titled Bee Venom Therapy, a detailed account of his clinical experience treating rheumatoid arthritis patients with injections of bee venom. Beck was not a folk healer. He was a trained physician making systematic clinical observations and documenting them in enough detail to be evaluated. His core finding was that a significant proportion of his rheumatoid arthritis patients showed measurable reduction in joint inflammation and improvement in range of motion following bee venom treatment applied in progressive doses over an extended period. He documented this across multiple patients. He noted which presentations responded and which didn't. He was careful enough in his methodology that his work has been cited in modern epitherapy research as the primary early clinical documentation of what is now called bee venom therapy. Here's the biological piece that makes Beck's observations interesting rather than simply historical. Bee venom contains two primary active compounds, melittin, which makes up roughly 50% of dry venom weight, and phospholipase A2. Melittin has been shown in laboratory and animal studies to inhibit NF-κB signaling pathways, the same inflammatory cascade that is a central target of modern rheumatoid arthritis treatment. Phospholipase A2 interacts with arachidonic acid metabolism, which is the pathway targeted by NSAIDs. Beck, working in 1935, was accidentally targeting the same molecular pathways that billions of dollars of pharmaceutical research would later identify as the key drivers of inflammatory arthritis. He didn't know that. He had no framework for NF-κB. He had clinical observation, patients in pain, systematic treatment, documented outcome. The biology that explained why some of them improved was already present in the venom. The explanation arrived decades later. Modern bee venom therapy research is active. It's also inconclusive in many important ways. Controlled clinical trials have produced mixed results. The effect size in rigorous double-blind studies is smaller than Beck's clinical report suggested. There may be a real effect in a subset of patients. There may be significant placebo contribution. The honest answer in 2025 is that the biology suggests a plausible mechanism, but the clinical evidence doesn't yet confirm consistent therapeutic benefit at a level that would meet current standards for medical treatment. Beck was pointing at something real. Whether he was pointing at it accurately, whether bee venom therapy as he practiced it actually produced the outcomes he documented, is a question the evidence hasn't fully settled yet. That's the difference between interesting history and proven medicine. Worth knowing clearly. Now here is the moment that makes this history genuinely remarkable. The point where a folk observation, unscientific in its framing, turned out to be ahead of formal science by 80 years. And this is where the open question we raised at the beginning of this video comes into focus. For at least a century before 1982, Appalachian and rural American tradition included honey as a treatment for stomach complaints, what people called biliousness, chronic dyspepsia, stomach troubles that came and went across years. The specific complaint varied. The treatment was consistent. Honey in warm water, taken regularly, sometimes with the addition of apple cider vinegar or ginger. The observation behind the recommendation was equally consistent. For some stomach complaints, regular honey consumption seemed to settle the problem. Not always, not dramatically, but with enough regularity that the practice persisted across generations. In 1982, Barry Marshall and Robin Warren identified Helicobacter pylori as the primary causative agent of peptic ulcers. They won the Nobel Prize for it in 2005. Before that identification, the medical consensus was that ulcers were caused by stress, excess stomach acid, and lifestyle factors. The folk tradition of treating stomach complaints with honey was not taken seriously in any clinical context. There was no mechanism to propose. There was no bacterial target to consider. After 1982, the picture changed. H. pylori is a gram-negative bacterium. It colonizes the gastric mucosa. And in laboratory conditions, honey, particularly honey with high phenolic content, demonstrates meaningful inhibitory activity against H. pylori. The phenolic compounds found in honey, including camphoryl, caffeic acid derivatives, and various flavonoids, interfere with H. pylori colonization at concentrations that are biologically relevant. The 2004 study that formalized this was published in the Journal of Medicinal Food. It documented in vitro inhibitory activity of several honey varieties against H. pylori strains. The activity was real. The concentrations required to achieve clinical effect in vivo, inside an actual human stomach, are a separate and more complicated question. Getting sufficient honey to the gastric mucosa at effective concentrations is not straightforward. The folk remedy as practiced was probably working at the margins of what the biology could actually deliver. But the folk observation that honey affected certain stomach complaints was tracking a real biological relationship. It was just 80 years ahead of the explanation. They were right about what honey did. They just had no idea why. A firesol des Pudusholf of Bayer his Arsens. That is the sentence that runs through all of this. The county physician in 1918. The 1890s dentist pressing propolis into a cavity. The beekeeper in 1920 who told his neighbour to eat a spoonful of honey every morning for his stomach. They were working with real chemistry. They couldn't name it. And when medicine advanced to the point of naming things carefully, the naming process didn't always stop to look back at what the nameless practices had been tracking. Now it's important to say clearly what doesn't hold up in this history, because the honest accounting matters as much as the validation. Honey as eye drops, a practice that appears in ancient Egyptian medical papyri and surfaced in 19th century American homeopathic literature, carries documented risk. Honey is not sterile. It can contain Clostridium botulinum spores. Introducing it to the ocular surface creates infection risk that the antimicrobial properties do not offset. This is not a practice with a real biological defense. It should not be revived. Royal jelly and fertility, a claim that circulated in 1950s beekeeping communities and appeared in popular health literature of that era, is at the level of anecdote. The biological mechanism proposed, estrogenic compounds in royal jelly affecting human reproductive hormone balance, has not been demonstrated to clinical effect in controlled human trials. The claim doesn't meet the standard this channel applies to biological arguments. It stays out. The honey and warm milk sleep remedy, cortisol suppression and melatonin precursor effects, has a plausible biological sketch, but the evidence is thin. The tryptophan content of milk and the mild glycemic response from honey creating an insulin peak that may support melatonin synthesis. There's a mechanism, one could argue, but the clinical effect size is small and the supporting literature is limited. It's probably benign. It's probably not doing much. Worth knowing the difference. What remains standing after the honest accounting is this. Honey on wounds. FDA-cleared MediHoney products are currently in clinical use for chronic wound management, precisely on the basis of the antimicrobial mechanisms we've described. The osmotic, hydrogen peroxide, and pH mechanisms are not in dispute. The clinical application is not folk medicine. It's current wound care practice that validated what the county physician was doing in 1918 without knowing why it worked. Propolis antimicrobial activity. Active research area. Real chemistry. Real mechanisms. Not yet at the level of clinical prescription, but far from dismissed. The 1890s dentist was working with something genuine, honey and H. pylori, real in vitro activity, complicated in vivo pharmacology, genuine folk observation that preceded the scientific identification of the target by 80 years, bee venom and inflammation, plausible mechanism, mixed clinical evidence, honest uncertainty about therapeutic effect size. That's the actual legacy of what the county physician carried in that leather bag. Parts of it were real, well-founded biology without the language to explain it. Parts of it were tradition that didn't hold up when examined carefully. Separating those two things is what the intervening 100 years of research has gradually done, and that separation is more interesting and more useful than either the romantic version, ancient wisdom suppressed, or the dismissive version, all of it superstition. The beekeeper who keeps hives today is working with exactly the same substances those practitioners worked with. The honey comes off frames the same way it came off frames in 1918. The propolis is still in the corners. The colony still has the same chemistry it always had. What changed is the ability to say precisely which parts of that chemistry do what, at what concentrations, against which organisms, and under what conditions. That precision is not an argument against the old practices, it's the completion of them. The men who used these things before the language existed were paying attention closely enough to know that something was there. They didn't always know what. They didn't always use it correctly. But they were watching the results carefully enough to keep passing the observation forward, generation to generation, until the science finally arrived to meet it. If you've kept bees for any length of time, you've probably had a neighbour, or a grandmother, describe something honey did that you half believed and half dismissed. It's worth going back and asking which half was correct. The answer is more specific and more interesting than either full belief or full skepticism would give you. If this kind of careful, biology-first look at what holds up and what doesn't is useful to you, subscribe. There is more historically grounded content ahead, the kind that doesn't ask you to take anything on faith, but also doesn't ask you to throw out 100 years of careful observation because it arrived without a citation.